Good afternoon, and welcome to today's webinar, A Frank Discussion, Provider Concerns and Barriers to Value-Based Payment in New York State. My name is Karen Labello. I'm Director of Education for the New York Chapter ACP. Our speaker today is Marcus Frederick. He is Chief Medical Officer for the Office of Quality and Patient Safety at the New York State Department of Health, and Lori Kaczynski. She is the New York State PCMH Operations for the New York State Department of Health. Before we begin, I would like to review a couple guidelines. All participants will be on mute. If you have a question, please raise your hand and we will unmute your phone. You can type your question in the dialog box on the right, and Dr. Frederick will answer your questions at the end. If we run over the allotted time, we will send the answers to your questions through email. If you are unmuted, please state your name and your organization. Then you can ask Dr. Frederick your question or comment. The webinar will be on the New York State PCMH page at the www.nyacp.org, and we'll be sending out the PowerPoint presentation following the session today. I would now like to introduce Dr. Frederick and Lori Kaczynski.
Yeah, hi everybody, and thanks for joining this lunchtime webinar. I just want to introduce myself. I'm a primary care physician here in Albany, but also the Chief Medical Officer of the Office of Quality and Patient Safety, and I'm heavily involved in this SIM grant, talking about value-based payments and so forth. And today is really a chance for you to give us feedback, and we want to know about barriers of value-based payment in New York. It's not about VBP, if it's good or bad. I'm not going to present on value-based payment or anything else. But we want to hear from you and your experience and potential barriers that you had in the past with payers and provider or practices to see what's going on in the landscape out there. I prepared a couple of slides in the beginning. I wanted to introduce just the larger framework for the first 5 to 10 minutes, but the rest of the time is really up for comments from you, questions, or a discussion about value-based payment here in New York. And again, thank you for getting on the call. Karen, can we move to slide 3, please? So, like, thinking about VBP, I broke it up into, what we're hearing from CMS and, on the national front. And as you might or might not know, that CMS put their value-based payment thoughts into their quality strategy, and I just named like the 3 highlights of their strategy: using incentives to improve care, and then tying payment to value through new payment models and changing how care is giving. I also embedded a small slide there that shows you some of these CMS value-based payment programs and when they get in place. But this is a clear guidance also from CMS that they're moving very heavily into this value-based payment world. Next slide, please. And then here in New York, we have our own way of looking at things. This started in 2012 with the State Health Innovation Plan, where we got together with many stakeholders here and thought about healthcare and a timeline and a time frequency until 2020. We brought forth some of the pillars, and you see them on the slide: improving access, integrating care, transparency, and promoting population health. But one of the 5 pillars is also pay for value and not volume. And this kind of leads to, Karen, if we can go to slide 5, to some specific goals in this value-based payment arena that New York State put forth. Not only that we want to have 80% of the population receive primary care in what we call an advanced primary care setting. It is a funny way of saying that, we would encourage practices to get ready and building capabilities for value-based payment, but also that there's a payment component that we would like to see 80% of care paid under value-based financial agreements or arrangements with payers. And again, VBP, I'm using the definition of value-based payment in a broader sense. I consider personally value-based payment everything else than fee-for-service. But I also consider some arrangement where fee-for-service is still being the predominant payment, plus some shared saving on top of that. That's also what I consider value-based payment. On slide 6, I just want to highlight, based on the SHIP, we have like two big demonstration programs. You heard probably about these, DSRIP and then the SIM. They're kind of like going in similar directions. DSRIP is more about healthcare transformation, targeting the Medicaid side. They have an overarching goal of reducing avoidable hospital use by 25%. They have these PPSs who are driving it, and they also use a VBP model, this roadmap that is available on their website, as driving value-based payment through this health system transformation. And then on the SIM side, it's a much smaller amount of funding that we receive, but we are targeting very specific primary care transformation, also including like a multi-payer primary care payment approach, meaning that payers should offer primary care providers, like a somewhat standardized value-based payment contract going forward. So you see that although these are different initiatives, that they're both wanting to move care more into this value-based payment world. Next slide. On slide 7, this is kind of like on the Medicaid side, there are specific deliverables that the DSRIP team has to deliver to make sure they fulfill all the requirements. Different time stamps there. You see 2018, 2019, and all what I want you to take home from this is that in the coming years, 2018, 2019, 2020, there are specific deliverables. How much or how based on the levels of VBP that are identified in the roadmap, and how much payment should be tied to these different levels. So it's not just that they have a roadmap, but it's also that especially the DSRIP team in New York State is held responsible for achieving these goals, and therefore New York State and the Medicaid side will do anything to kind of move providers into this arena. Slide 8 is just a high-level overview how the roadmap defines VBP. There is the distinction between risk and upside only. That is the level between level 1 and 2, and then level 3 is going into has like downside risk arrangements, and I'm not going to go more into detail than that. Slide 9, I just wanted to show that you heard of the CMS approach, the Medicaid and New York State approach, but there is a host of a commercial value-based payment landscape, and it's very complicated. Almost all the payers in New York State, they have their own value-based payment model. Some of you already have experience with some of these models. What we are trying to do with the SIM and also with the DSRIP initiative is trying to align some of the thoughts around VBP with some of the commercial payers behind that. That starts with measurement alignment. We just started a stakeholder committee on the state level to think about how can we align not only from the commercial side but also from the state side some of the measurements on the primary care side. And it goes over thinking about aligning also the approach to VBP, that we as a provider do not have different arrangements with different payers and being paid on a different level from multiple payers. And it would be nice if that could be aligned more and more. We are really just at the beginning stages of having these discussions. We kind of like are having discussions on a regional level with different payers and making sure that we will drive and argue about the alignment also to the commercial payer side. So this was like a really high level overview about what I just wanted to set a baseline here. On slide 11, we prepared a couple of questions just to start the discussion. And again, this is not about is VBP good or bad. It's more about your experience in the field. with VBP, and have you had any contact with the insurance companies? And if so, we are interested in really what is going on a ground level. And the basis for this webinar was really that we heard that there are certain practices out there that we just want to make sure that also we give a voice to you, that you can respond back to us. So the questions are: is your primary care practice planning to engage in VBP arrangements? What might be the barriers to be engaging with payers? Or have you had any experience being rejected by payers for engaging in VBP arrangement? And those are kind of just like starting points for the discussion. But I'm more able and willing to answer questions, but I would like to be this very casual interaction of thoughts about VBP and barriers. With that, I want to give it back to Karen, who can make some comments, and then hopefully we can drive into the questions.
Thank you, Marcus. That was a great overview. This is now an opportunity for the attendees to either raise their hand and verbally ask a question or a comment, or you can type it in the dialog box on the right-hand side of your screen and submit it. We do have a couple questions that came in during your presentation. I'd like to read them now while the others are thinking about their comments and questions. The first question is: my concern as a primary care physician is that these value-based purchasing programs are asking physicians to provide the most important preventive care to take on more tasks and risk as the only means to get adequate reimbursement.
Thank you. This is, of course, me, or I as a primary care provider. I'm also very concerned about, adding on things to my list of things to do without being reimbursed more. And this is a clear strategy also from the state, in at least on our SIM side, that we've got to make sure that if we have to take on more responsibility and more risk, that we also will get paid more. And this could start with a PMPM payment, getting reimbursed at least for the work that we have been doing in building capabilities in our practices. But it should also be viewed as, during then the VBP contract, that there should be earning potential there for the primary care providers that were prior not accessible for us. And I think that is a very, very good point, that we have to make sure that that the reimbursement piece for the primary care provider is not a second thought or an afterthought, but really one of our premier thoughts. And we are, at least from the state point of view, are continuing to drive that point home in our discussions with the different stakeholders and with the payers going forward.
The next question is: how do I find a list of the commercial plans that will reimburse me for the PCMH-NY? I can't change my practice for any one particular payer.
Yeah, another good point. It's unfortunate that there are very limited or limited payers out there who are actually paying for PCMH for the recognition program. We hope that by aligning around this new New York State PCMH, that more payers will reimburse you just for the recognition. I just know that the only payer that reimburses you right now is Medicaid, giving an incentive payment. We hope that in the future other payers will also make this as a basis for higher reimbursement. The other argument that I just want to bring up is that PCMH as a recognition might probably not enough to drive higher reimbursement from payers. And this is certainly, what we try to target also with these transformation programs, that you should be able to perform also better. And that is probably where what I heard from the payers, at least, that recognition alone is not enough, that you also have to then perform at a higher state by driving some utilization measures or something down, or on quality metrics. And this is something that I feel very strongly that once you have the recognition that you will be at a different state and able to perform better on these measures than if you don't have the recognition. But I hear you loud and clear. This is I just hope that the payers in the future will consider the recognition also. And the list, there is no list, because I don't actually know if any commercial payer just pays you based on the recognition going forward. Next question, Karen.
Okay, thanks, Marcus. So they're typing in more questions than raising their hand and being unmuted. So I will read the next question.
Right.
What is the difference between PCMH and APC?
APC was a construct that we felt that the PCMH 2014 level recognition was not sufficient to build capabilities and practices for value-based payment. Therefore, the state and stakeholders, primary care physicians, the physician associations, and payers got together and decided on this advanced primary care model that built or started building their own spin, if you will, on PCMH 2014. It was considered a higher level of recognition, and we started implementing that. And then NCQA came out with the PCMH 2017 model last summer, and it was clear from the very beginning that NCQA really changed their way of doing things. One of the critique points of PCMH 2014 was that you got your recognition, and then for 3 years you didn't have to change anything. Another critique point was that it was just filling out boxes without really severely changing processes around to improve access and so forth. And then there was this, you're submitting, a catalog of requirements, and, that's been reviewed. And then, at one point you get the recognition or not. It was very not helpful for the practices to actually work on this. And so when PCMH 2017 came out and NCQA started, completely changing their model around this, they suddenly had a process where they gave you feedback during the application process. They suddenly had a process where every year you can do a little bit and not like every 3 years a lot. That really, drove home. And they changed some of the requirements as well, going in the direction that New York State felt was very important, such as behavioral health integration, care management, the health IT, and also the value-based payment process, that we felt that APC and this PCMH 2017 was so aligned that it would make sense for us to just go the last step and say, why can't we just align on one, transformation program going forward? And so we talked inside here the department with our friends on the Medicaid side, and we came up with this New York State PCMH model that was developed, with us here on the state side, with the primary care physicians, with the physician associations, but also with the payers, and they all agreed that this could be, a way going forward, and therefore we came up with this new New York State PCMH model. So in a way, it is APC. We since then retired that program because it makes no sense to have then this APC program going forward, and we now unified under this New York State PCMH program that NCQA helps us administer, but New York State has still the overarching control over it, and helping with the SIM funding to drive transformation and help practices to transform to a higher state. So that was in a nutshell why APC is obsolete now. It's being retired, and why everything from going forward from April this year is New York State PCMH. And we hope that what I mentioned earlier, our hope is that additional payers will use New York State PCMH as a transformation model, but also as a recognition model for thinking about paying practices more for achieving that recognition in the future, because there are not more programs out there. There's only one everybody agrees upon. And I feel that payers also start understanding the issue of, aligning around one program, aligning around certain measures that are the same, so physicians can perform better at these measures versus, having payer A having 30 quality measures and payer B having 20 quality measures, and they're not aligned at all. And, overall, you end up with 150 quality measures in your practice. And everybody understands that doesn't help everybody. So we are trying through this vehicle of New York State PCMH kind of to align the thinking, not around primary care alone, but also in which direction we are going with VBP, which direction we are going with measurement and so forth. That's the thought behind it. Thank you. It was a great question. Next question, Karen.
Okay, thank you. Next question. We are involved in several VBP programs. I have two concerns. One of our payers includes everything a PCP would provide, including immunizations. I feel we should at least get reimbursed for the actual product. Second, integrating behavioral health specialists in our solo practice is very difficult.
Yeah, again, two great points that you're making. This is like a concern, and I take the second question first, the behavioral health integration. This is not easy, and I know that especially smaller practices are struggling with that piece. And we are trying to find ways around it by aligning with, the Office of Mental Health here and giving guidance on how this could be accomplished best. We are not feeling that, every practice should have a behavioral health counselor in the practice or so forth. And there could be, in the future ways of sharing services. In the meantime, I feel that, there still needs to be more work to be done. Behavioral health integration is a huge topic. There are some, very promising pilot projects in the city that Montefiore and also Columbia are conducting right now, helping also smaller primary care practices to come up with a framework how to better do behavioral health integration. And we will share with that once we have more data on those pilot projects. The second piece was about the measurement, and I again agree with you wholeheartedly that that if one pair, and I don't know if Karen, maybe you can read that first piece again. I just want to make sure that I completely got it.
Okay, one of our payers includes everything a PCP would provide, including immunizations. I feel we should at least get reimbursed for the actual product.
Yeah, I cannot talk specifically to specific reimbursement for elements there on payers quality part, but I think the underlying issue is again that one payer is asking you to perform on a special quality piece versus another payer who is not using that and has other quality pieces that he wants you to perform on. And this is, again, going back to this non-alignment that probably needs to change in the future, that payers should kind of agree together for a common, what we call a common core set of measures around primary care. And as I mentioned earlier, we started the discussion here on the state level with different stakeholders. We called it the APC scorecard last year, but we are talking now about a New York State primary care scorecard or primary care quality card that would, set up like a very parsimonious set of measures. I just pick a number, 20 measures that everybody could agree on, that the payers would use the same methodology as Medicaid would use the same methodology, that the commercials would use the same methodology, and that the provider is not confronted with a different way of being measured from different payers, that everybody can kind of agree. That does not mean that every payer has to adopt these 20 20 measures. There could be then, a subset of these measures, but at least the providers will understand then how it's measured, and that payer A, if it's being measured at the same thing as payer B, that they are using the same methodology and not going in different directions. Next question, Karen, or next comment. Maybe we can take now a raising hand.
I've offered, and I haven't seen any hands raised yet. So, and individuals on the call are welcome to raise your hand, and I will unmute your phone, and we'd be happy to have a verbal discussion. In the meantime, I'll read the next question/comment. As an internist, I don't see a lot of Medicaid in my office. I see more Medicare patients. How does the alternative payment model you are discussing for New York align with the macro MIPS requirements?
Yeah, again, great question. And the macro MIPS is, of course, on all our minds going forward, because it's such a big piece of primary care in particular. Most primary care practices that I know also have similar issues, that they, although provide some care for Medicaid, but Medicare is the bulk of the practices there going forward. So how we are going, we have a strong voice in Washington thinking about macro. We are also trying to see where we could, as a state, more align around those issues. As you know, one of the one of the MIPS requirements is that you are in a practice transformation program, or that you being recognized there. And so with being New York State PCMH, you're fulfilling that requirement. And this is kind of like another way for us to, why we kind of aligned around that, to make sure that you as a practice would have it easier to fulfill all the requirements that you need for CMS. But it doesn't stop there. As you know, that Medicare puts also out a primary care scorecard and starts measuring. And I think that, our discussion here at the state level will lead us also to align around this measurement piece from CMS to being recognized. And there are other discussions around, what could be in the future after DSRIP and after SIM sunsets. And, Medicare, they have programs here in New York, but they're fairly small. And many people here in the department think that, there is a way of maybe tying Medicare more in to do something for, all primary care providers here in New York. I cannot talk about specifics, but this is kind of what we are thinking. I'm talking about the future. At the moment, it feels like, Medicare is going into their own direction, and they have certainly certain challenges, as we all know, on the political side with the new administration, to find, kind of a new voice going forward. But we are keep, our channels open with them, and seeing that we can at least align, on the measurement side, but hopefully also on the payment side going forward. And I will leave it at that, and we'll continue to inform you if there are more discussions around this. But we are engaged in discussions with Medicare around payment models, solutions, regional solutions, and also statewide solutions. And there's hopefully more to come in the next coming months. Next question, Karen.
If you participate in DSRIP already, can you still do APC?
In what already?
DSRIP.
I did DSRIP. Yeah, and that was one of the big things that we had to work out internally in the department. And just to give you a background, one of the big no-nos in having grants from CMS is what we call double dipping. And in a way, DSRIP is also funded in large parts by CMS. And so we had to make sure that the practice who is in DSRIP is not getting at the same time for the same services transformation dollars. And so we kind of defined it as that. So the practice who is in DSRIP can be in APC. That is very clear. You just have to be careful that you are not getting, transformation money through your PPS at the same time while you would get transformation money through the SIM side. And that is kind of where we left it at that. There are a lot of questions, like detailed questions, and I can, if you want to reach out to me or our team here at the state to give you specific answers, because we need to be more specific, what that means. But in general, we kind of allowed that any practice who is participating in DSRIP can also be part of the APC or New York State PCMH going forward. Next question.
Okay, the next question. I would like to understand what are some specific examples of barriers to engaging behavioral health. Would be helpful to understand a little more detail on this.
Yeah.
And there's another part to this, Dr. Friedrich. I can open up your telephone line if you just raise your hand on your screen. They asked if there's a way to open up the question to the audience members to gather one or two answers to this point. If you raise your hand in your dialog box, I would unmute your phone or your microphone, and you would be able to talk verbally to us. So please feel free.
And I will have Lori help me a little bit with this question. Lori?
Yeah, we've been hearing a number of questions, both coming through our transformation agents on the ground, as well as their work in practices or practices that were referred by the transformation agents to inquire by email or phone calls with us. And a number of the topics that were coming forth really were centered around having to do with plans and existing contracts that practices have with plans. And one area that we were discussing most recently had to do with representatives from plans that lacked sufficient knowledge in having discussions about particular contracts in a VBP environment, as being one case. Another barrier that we're finding is behavioral health integration. It seems to be posing another issue where there are expectations in and around that particular area. But again, it's kind of a wide scale of what we're hearing in terms of enabling certain environments to be able to get into a VBP contract. Another has to do with limited attribution. There's a number of things, but I think behavioral health is probably one of the primary.
But do you have specific examples of what the barriers are to behavioral health integration? That was, I think,
okay. I thought it was a VBP and payment with that. Okay. For behavioral health integration, I think one of the key things that we find, and I think it's true across most of the country right now, is the availability of behavioral health specialists, and also a clear definition of what would constitute behavioral health integration in a practice. Whether it's someone that would be off-site, again, availability, also training within a primary care setting to be able to move forward beyond the assessment and also to the treatment modalities. And that seems to be probably the most common theme.
Next question. Sarah?
If you achieve New York State PCMH level, do you still keep your current PCMH level?
I'm sorry, you need to be a little bit more specific on that. So would that be PCMH 2014 level 3 as part of that discussion?
Okay, well, we'll wait till the audience responds to that. That's all they wrote.
Yeah. In general, we can answer it. So there is only one level. So if you have PCMH 2014 and you do the next level would be New York State PCMH, you would just have that New York State PCMH level. There is no value for you keeping that level 3 2014 recognition.
No, and these practices will all have to go through some semblance of annual reporting, which will be in a New York State PCMH requirement.
Okay. The next question. We were told that because we are in CPC Plus, we can't be in APC. Is that correct?
Now, that's, again, a very good question that we keep discussing here on the state level. There was, again, what I mentioned earlier with DSRIP that counts also for CPC Plus, this issue about double dipping, meaning that if you are in one transformation model, that you cannot be in another model. So in the beginning, we kind of said, yeah, you cannot be in CPC Plus and in APC at the same time. We are changing that approach slightly because we feel that there are some CPC Plus practices out there that could benefit from the transformation agent work that we are providing in this under the CIM grant. We have had discussions with CMS, but we have not come to a conclusion right now, and we will keep you informed. We know that there's a need there, and we are not only hearing that from practices, we are funnily also hearing it from payers that would help or that are pushing us to raise that question with CMS and discuss it more. But there was a leadership change on the CMS CPC Plus level right now, so we haven't gotten too far in those discussions. But this is on our mind, how CPC Plus practices could participate in APC going forward, but we are not there yet.
So, we're following this pretty closely, obviously, as Mark has framed out, and I think that it's leading into a very positive direction to be able to provide transformation support. But I do want to say this, for those practices that are CPC Plus and are currently recognized through NCQA, which I think there's 286 practices across the state, bear in mind that, going through this process doesn't prohibit you from continuing in New York State PCMH. It only really has to do with the support of transformation agents. So we're encouraging all of the CPC Plus practices to continue to march through. Those two, getting your recognition isn't in conflict for participating with CPC Plus, only having transformation assistance to help the way. We're working on it.
Next question.
Hey, this is the last question we have in the queue for now, so please feel free to type in any questions if you have one. How does one incorporate patient non-compliance issues in documentation for VPB? I can do the right thing and order scripts and tests, but patients need to actually do it. Your thoughts and insights?
Yeah, it's, again, a great question. This is like patient non-compliance is a huge issue that is being raised, almost every time you talk about VBP. We don't have a good recipe for addressing that. We are thinking about it here from the state, about patient compliance and patient engagement. Is there something that we could provide, like a framework to help practices who are struggling with this? But it is a ongoing issue, and the last time I looked, the numbers were quite astonishing that of my patients in the practice, and in general how large the number is of patients non-compliance with what we tell them to do, and also taking their medication non-adherence, and so forth. It is a huge issue. I somehow feel that we need to continue discussing this factor also with the payers and potential payment arrangements should but make sure that they have an eye on that issue in going forward, that it's not all on the fault of the primary care physician. And I think that could be also directed with certain measures that are independent of patient non-compliance. But everybody is aware that there is this percentage of this ground percentage that there's as hard as you try as a physician, that you cannot bend some patients around and making them more compliant than they are, and you should not get penalized for those patients. And I completely agree with that. And I hope that in the future, when we develop measures, the scorecard, that we will take that into account. Measures that are dependent on patient compliance are, in my view, not very good measures and not very timely, because this is an ongoing issue that is being discussed in the literature, and that I feel that, however we want to measure performance of practices, that we should take that into account, that patient non-compliance, is and continues and maybe even grows as an issue going forward. Next
Thank you,
question.
Dr. Rick. That's the last question in the queue right now. I'm just going to give a brief reminder that this webinar is being recorded, and it will be on the PCMH page of the New York Chapter ACP website at www.nyacp.org. And I will be following up with a handout of the slides later today.
Can before we hang up, because we have another 10, 15 minutes, can I just ask a specific question to the providers? Like, one of the things why we started this webinar, and we had another discussion with our transformation agents earlier, that there is a sense out there that providers are being rejected, even if they want to engage in a value-based payment contract, and rejected based on number of lives that the provider is serving for the different payers. And I just want to open up, because this is something that I have heard before anecdotally, but I have not heard specific providers saying, yes, it's actually, one or other payers that are doing, that are showing this behavior. Because if that is the case, it would really hinder us in, reaching our VBP goals. And it would also not be fair to primary care providers if a payer says, you don't have enough mass to, to help me or to help me reach my goals, and therefore I'm not giving you a VBP contract. Just want to, make sure that if anybody had experiences like that, we would like to hear about that, because this is not what we try to intend with this VBP. And if there are barriers like that, we can have here on our level the necessary discussions with the payers. Thank you.
So I don't have any hands raised to make.
No problem. So, if there's any second thoughts on that, please, feel free to reach out either to the New York State ACP team or even, the Department of Health. And we can, I think I have my email contact information on the slide deck that we can hand out. So would be interesting to hear from you. So again, thanks everybody for your time. Really appreciate you in your busy schedules making time during your lunch hours for this webinar. Thank you, New York State ACP, for hosting this. And with that, Karen, do you want to say some closing comments?
Actually, I just had a hand raised. So Dr. Small, can you hear me?
Yes. One brief question. I found out one of the centers that I worked with, since they were FHQ, I did not have to report in terms of MIPS. But there was sometimes the small offices have less understanding of the whole process, and then the MIPS was based on the NPI, the physician, not the center. What type of outreach have you done beyond the physicians, but to administration? Because sometimes they're a little fuzzy in terms of what we need to reach the goals or the requirements.
Yeah, thank you, Dr. Small. It's a good point. That is an ongoing issue with reaching not only practitioners but also administration and informing them about the goals. We have from the state, we have arrangements with the professional societies, but I have to admit, if there's one thing that New York State could need some help is like really great marketing and marketing it to also administrators. We could do more, and the first thing we did, we have a new revamped website which has all the information under DOH, but there could be more outreach. One thing that we are currently thinking about, especially having kind of a VBP seminar for smaller practices going forward, where we would not only encourage practitioners, but also administrative staff to attend, to make sure that everybody kind of understands, you know, the basic principles of VBP and how this could look like, and giving them hints about, you know, what to ask, what question to ask in potential discussions with payers going forward. So I recognize that there's a tremendous need for, you know, for education around VBP, and also what you raised on the, you know, MACRA and MIPS. This is also, you know, another system that people need to understand, which is, you know, different than what we are trying to do here on the state level. And I feel that, you know, we need to continue the discussion and educating, you know, all the practices involved in this.
Thank you.
You're welcome. Karen, any last final words?
Yes, I apologize. Dr. Small, thank you for your question. There are no other questions in the queue today. Thank you, Dr. Frederick, for the very enlightening presentation. If anybody has any additional questions, please feel free to send them to me, and I'll make sure Dr. Frederick gets them. Once again, I mentioned I will be sending a copy of the handout later on today to everybody, and it'll be on our website. Thank you once again, Dr. Frederick and Lori. Have a wonderful afternoon, and to all our attendees today, have a great afternoon.
Yeah. Thank you, everybody. Bye-bye.
Good night. Bye-bye.